It is my pleasure to welcome Dr. Gupta, an assistant professor of medicine at the University of Vermont. Today, we'll be discussing his JACC Interventions manuscript reporting the national trends and outcomes of acute myocardial infarction after transcatheter aortic valve replacement. Dr. Gupta, thank you so much for taking the time to join us and share your expertise.
Thank you so much for having me and allowing us to share our work.
First, can we start, with a brief background about the topic, the questions that you and the team aim to answer, and the population that was studied?
Yes, absolutely. So as we know, coronary artery disease is common in patients undergoing transcatheter aortic valve replacement. As TAVR is extending to younger and lower risk patients, there is increased possibility of future coronary events with long residual life expectancy. The cornerstone of acute MI management, as we know, is prompt invasive evaluation with coronary angiography and revascularization with PCI or coronary artery bypass grafting, as indicated by coronary anatomy.
Mhm.
Prior studies have indicated that the use of invasive revascularization is lower in post-TAVR patients compared with all comers.
Mhm.
However, these studies were limited by either small sample size or being more than 5 to 10 years old, where TAVR was only being performed for high-risk patients, or with a particular focus on STEMI patients. So therefore, the purpose of our study was to study the incidence of then use of revascularization and in-hospital outcomes of acute myocardial infarction in patients who received a prior TAVR using a large contemporary nationally representative data set.
Mhm. Thank you. And kind of for the listeners, the results of this manuscript are truly comprehensive and it covers multiple aspects of this patient population. Can we start with the incidence, timing, and characteristics of the AMI after TAVR population?
Absolutely. We had our overall patient population was approximately 200,000 patients
Mm.
who were included in the Vision clinical database who underwent TAVR during the study period from 2016 to 2022. Of these patients, 144 were hospitalized with STEMI and 1,321 were hospitalized with NSTEMI. The
Mm.
median follow-up duration after the TAVR was 3 years. The incidence of STEMI was rare. It was 25 events per 100,000 patient years of follow-up. And that of NSTEMI was 229 events per 100,000 patient years of follow-up. And what was also interesting is that the median time from TAVR to either STEMI or NSTEMI was greater
Mhm.
than 1 year. Specifically, it was 429 days for STEMI and 480 days for NSTEMI. So in conclusion, AMI events after TAVR were rare in our study, and most
Mhm.
of these events happened at greater than 1 year after the index TAVR procedure.
And kind of moving toward diagnostic treatments in terms of coronary angiography, revascularization, can you share the results and how much the treatments and the diagnosis were performed on these patients?
Absolutely. So this was one of the main purposes of our study was to
Mm.
see how are these patients managed compared with all comers with acute MI. And we wanted to do this, in a manner best possible to remove confounding with
Mhm.
a retrospective design. So we did that with the use of propensity score matching. I'm going to divvy this up by STEMI and NSTEMI separately.
Mhm.
In the STEMI cohort, the use of invasive revascularization by either CABG or PCI was similar in patients with a prior TAVR when we
Mhm.
compared them with the all-comer population of STEMI patients without prior TAVR in the same study period. The numbers were 65.3% rates of revascularization for prior TAVR patients and 63.9% for non-prior TAVR patients with a non-significant p-value. When we move forward to NSTEMI patients, we saw similar results that the use of coronary revascularization was similar in patients with or without prior TAVR, and these numbers were 41.4% in the prior TAVR cohort and 41.7% in the non-TAVR cohort, again with a non-significant p-value. So to
Mhm.
summarize, in our study, the use of coronary revascularization with PCR or cabbage, or even coronary angiography, was similar in prior TAVR patients compared with all comers with AMI who were propensity matched on baseline characteristics that were age and relevant comorbid conditions.
Thank you. And these, very encouraging results in terms of this sicker population. What about in-hospital outcomes, specifically in the matched population? Are there any differences, in mortality and other outcomes?
Yeah, so I think before we go into the results, I mean, even with propensity matching is the best we can do in a retrospective design. But a residual confounding remains, because on average, the TAVR patients were 10 years older than the non-TAVR patients. So even when you match them for age and other measured covariates, there could be residual confounding. With that in light, the absolute in-hospital mortality in prior TAVR STEMI patients was 27%. So that's very high. It's approximately 1 in 4 patients did not survive. And that was higher than the no prior TAVR STEMI patients, and the in-hospital mortality in them was 16.7%. One might see and look at, 16.7% mortality in all-comer STEMI is not what we see in real life. Those numbers are more close to 8 to 10%. And but we have to realize that when we propensity match the all comers, we are selecting a higher risk profile of all comers. So even with that, the in-hospital mortality in the prior TAVR patients was higher than in all comers with STEMI. When we move forward to the NSTEMI population, here the results were slightly interesting, and they were reversed. And the in-hospital mortality in the matched population was lower in the prior TAVR group than in the non-TAVR group, the numbers being 5.8 and 8.2%. I will add a caveat that, when we are looking at the all-comer non-STEMI, again, we have selected a higher risk group, which are propensity matched by age and other comorbid conditions to the TAVR cohort. And so the absolute mortality numbers are much higher than what we see.
And again, really comprehensive analysis. And I think, we covered multiple aspects of this patient population. Dr. Gupta, what is the message or the conclusion that you want the audience to leave with today?
Yes. So I think, the findings of this study were very relevant to us, and I hope it's to other clinicians. So the first, important conclusion is that the AMI events after TAVR are very infrequent, and they happen late after the index TAVR procedure. The practice in our center and in the US has moved more and more towards more conservative management of CAD and treating the valvular heart disease first. I think this practice, based on our conclusions, appears safe. Secondly, there has been concern with underutilization of coronary angiography and PCI in patients who received a prior TAVR due to difficulty with or perceived difficulty with coronary access. Although with the administrative nature of a data set, we specifically could not study that, it was reassuring to us to see that the coronary revascularization rates for STEMI or NSTEMI were similar in prior TAVR patients compared with patients without TAVR. It is humbling to know that in-hospital mortality in STEMI patients with prior TAVR is very high, with approximately 1 in 4 not surviving to hospital discharge. So future studies should look at understanding why is this the case and what measures we can take to improve the STEMI outcomes in post-TAVR patients, which is a rare event, but when it occurs, we want to do better to manage these patients.
Thank you again, Dr. Gupta, for joining us today. And it's truly, I think, a very important analysis that set the stage for future studies in this specific patient population. And we invite everyone to go over the full manuscript published in this issue of JACC Intervention. Thank you again, Dr. Gupta.
Abdullah, thank you so much for taking the time and allowing us to share our work.
Thank you.